Hi, everyone. Thank you for joining today's webinar on inside an IVF lab and the process of in vitro fertilization. Let's wait a few seconds to see more people join, and then we'll get the presentation started. All right, so we'll jump in and people can join as they get into the Zoom. So go ahead, next slide. So today we're going to mainly talk more of a conversational, casual webinar than what we usually do. So we're wanting to give you guys the opportunity to ask your questions in real time before you go into your fertility treatment or looking at other fertility clinics. You can use the Q&A box at the bottom or use the chat box, whatever you're comfortable with. We'll be looking at both, but you can leave your questions there. Next slide.
Okay. Hi, everybody. My name is Robyn, and I am the IVF Laboratory Manager here at our facilities. And I began my career as an andrologist, so I worked with sperm out of graduating from my undergrad at Cal Poly SLO. And I actually started here in LA, which was about 15 years ago. And then I also continued my education at Oxford and got a master's degree in clinical embryology and hoping to complete my PhD within the next few months as well. And I've been here at our IVF lab for about 5.5 years now. Next slide.
So my name is Brittany. I have been an SCRC employee for 3 years. I am 31 years old. I'm married with a 2.5-year-old son. I experienced fertility challenges when I was 27 years old, when I was trying to conceive my son. And it took about 10 months to conceive my son naturally. We did have a miscarriage previously before we found out that conceiving our son was a success. But during those 10 months, I really adjusted my diet. I became consistent with exercise, supplements, and trying my best to practice stress management. And now I'm currently um, undergoing secondary infertility. And about 6 months ago, we tested all my blood work, and it turns out I have low AMH, which is your ovarian reserve. So it's low for my age, and I was recommended to just go through IVF, and that IUI probably wouldn't work. And so I decided to do IVF after my first IUI failed in January. Next slide. So a little bit about SCRC. We have been open for over 25 years, experience with infertility and helping so many individuals and couples get pregnant for even more than 25 years. We have two co-founders, Dr. Suri and Dr. Danzer, who are at the top left. And then we have 3 female physicians, all 5 physicians spread across all 4 of our locations. We have Beverly Hills, Pasadena, Santa Barbara, and Ventura. And we do have on-site surgery centers and embryology labs at Beverly Hills and Santa Barbara. So those are kind of our everything you need in one house, basically. Next slide.
And part of the reason why we wanted to do this webinar today is to raise some awareness that July 25th is World Embryologist Day. And Louise Brown is our world's first IVF baby. So we just want to draw, some more attention and hopefully spread our knowledge about IVF and what actually goes on within an IVF laboratory. Next slide. And we're starting off with this slide just because I feel like for women, it's kind of the elephant in the room, right? Everybody knows that the older you get, the harder it is to get pregnant. And also the quality of your eggs or your chromosomes, your genetic status of your eggs are also going to decrease. And Brittany, I think where was your number?
So my AMH was 0.6. So mine hit the range of 40 to 44 age group at my 31 years of age. So mine was definitely significantly low. So, I have good quality eggs because of my age. However, I don't have that many left.
Do you think you would have sought IVF treatment as quickly if you didn't work in the field?
I probably would have thought everything was normal. I probably would have gone to my doctor at the 1 year mark of trying to conceive naturally and see, being in the field, I knew what to look for. I knew what tests that were needed to find out like my answers. So luckily, about 3 or 4 months into trying naturally, we decided to go like blood work route and ultrasound.
Mm,
So I was lucky there, but I would love to spread awareness for all women to get their AMH checked no matter their age.
yeah. And I think when you're in your early 30s or even late 20s, at least for me, it wasn't on my mind really,
Mhm.
thinking about having a baby or even, seriously trying to think about my future and what it would mean. Even if you're not having kids, it's not a horrible idea to get your AMH tested because then it prepares you for, in 5 years, if you start trying or if it's something you're interested in, you'll already kind of have set the stage and kind of know what to expect. But I know for me, it wasn't anything, even I mean, when I was 25, I worked in the field and people would mention it and I'd be like, I'm good. And yeah, so like you kind of mentioned, I don't think it's a bad thing just to get a test and kind of find out where exactly you stand.
Yeah, exactly. And no matter where you are in your life, I think it's a good test to do just to give yourself a game plan.
Yeah. Next slide.
All right, so during the egg retrieval process, it's about 2 weeks, depending on how your body reacts to the medication. So everyone's different. We kind of give them this ballpark timeline where it's 10 to 14 days of injections, 5 to 6 ultrasound and blood work draws. The trigger shot is very interesting. When I went through the process, I thought it was a single, just one injection. It really depends on how your body is reacting to the medication. Mine ended up being two different trigger shots. And then I believe it's like 26 hours is when you have your retrieval. And that's a 15-minute procedure under anesthesia.
Yeah. And the next slide, I think, is the,
Yeah.
okay.
So, like I mentioned about injections and medications, before this process and being in the field for just a little while, I did not realize that it was three different medications, which would be three separate injections a night. For some reason, my brain thought, okay, I can just mix all the medication into one syringe and inject it all into like one single injection. So that was something I didn't expect. And I did my injections for about 12 days. I know some people who react really well, and it's only 7 days of injections. It really just depends on how your body's reacting and how your follicles are developing during the process.
Did the shots themselves hurt?
No, actually, surprisingly not. One of the injections does burn as it's going in you, but the needle itself doesn't hurt. Um, but I do see how it can be painful, like if you're really nervous and you're doing it by yourself and you just like jab, then it would like leave a bruise later on. But I took my time, and most of them my husband did for me, so I was very lucky. But towards the end, when they introduced a morning injection, I had to do it myself. And so after I did that injection, I just felt like Superwoman. It's a very empowering experience, even though it's not something that every single woman goes through. Um, like I mentioned, I had two different trigger shot medications. Um, Ultrasound and blood work were done about every other day. I had 12 to 15 follicles. Most of my follicles were on one side. So I did feel uncomfortable halfway through the injections because one side was producing more follicles than the other. The day of retrieval, I was very nervous, but all the staff are so amazing. They check in on you and make sure you're feeling good. The anesthesiologist came over to me and gave me a little bit of medication to kind of calm my nerves. But I felt like I was in such good hands. I really didn't have like any worries at all. It was just like, the process of a procedure in general is nerve-wracking. Recovery was harder than I expected, specifically days 1 through day 4. I took the day of the retrieval off and the day after as well, to kind of really focus on my recovery. Um, I felt completely back to normal, to my normal self. No bloating, no discomfort, no pain. By day 9, I know that's definitely different for everyone else. I know probably your experience was a lot different than mine. But I know some people who the next day it's like they didn't even have a retrieval at all. So it really just depends on your body and how it reacts. And then I highly suggest you speak to your physician about recovery guidelines and restrictions. For example, my doctor wanted me to walk the day after retrieval, and I listened to my body and I just didn't feel comfortable, um, or confident to like walk down the street by myself. So I waited a little bit longer than that. Just listening to your body and reaching out to the staff on what they recommend.
I think you said one comment that I liked, that when you gave yourself your own shots, it was empowering. And I talk to a lot of patients undergoing IVF, and they use a lot of adjectives of overwhelming, stressful, disappointing. Um, but I think that that's the first time I've heard somebody say, they felt empowered by it. And when you think of it from that angle, it is a process that can be very empowering, like what your body can do, what you go through, the surgery you go through, and then what your embryos are able to do in the lab and ultimately create a baby. I just like that word that you used.
All right, next slide.
Okay, so this is just an overall timeline of what kind of happens on each day. I talk to a lot of patients who can kind of get overwhelmed with the whole process once they undergo the retrieval that Brittany was talking about. It's all kind of a gray area about what happens in the lab. So day 0 is what the IVF lab refers to as retrieval day, sperm preparation day, and also insemination day for IVF cycles. And then also if you're doing an egg freeze, day 0 is also the day that the eggs are frozen. So for the egg freeze cycles, day of retrieval is also the completion of your cycle. But for IVF patients, your eggs and embryos are in the lab up to 7 days. So day 1 is when we check and see if after our insemination or our ICSI process, has occurred, what eggs have undergone and properly been fertilized. And then in our laboratory, we do not take them out of the incubator for days 2 through 4. Some labs will do a day 3 check to kind of count cells and see what the progress is. We prefer to leave them in their gas-controlled incubator environment to hopefully provide the best environment for them to grow in. And then day 5, 6, and 7 is when we take out your embryos and we grade them. If you're doing a PGT or genetic testing cycle, that's when we grade the embryos, and ones that have reached a certain stage, we do biopsy them, and then we'll send out these biopsied cells for testing, and we freeze the embryos themselves. If you're not doing a PGT or genetic testing cycle, then the embryos are just graded, organized, and then frozen if they meet that developmental stage again. And then it can take up to 15 days for those PGT results to come through, which I know can be pretty stressful for patients. We get a lot of phone calls asking, did you hear anything? Did anything come in yet? Some days we do get results sooner, but every once in a while it can take that up to that 15 days. Next slide. So on day 0, one of the important steps is processing the sperm for an IVF cycle. And the whole point of processing the sperm is to optimize it for fertilization. And there's a few different ways that we can do that. A very popular way currently is the Zymot processing chip. So in that case, what we do is we add the semen all to a chip, which separates and organizes the sperm itself. There's a few other ways we can do some washing, which includes centrifuging. Historically, there's some research that says the best way to process is to skip the centrifuging step, because centrifuging can decrease the DNA quality of the sperm. And then the semen component. So we'll also have patients that come in that get very worried about their overall volume of the sample, but it's important to remember that it's what's inside the sample. So you can have a very high volume sample with low concentration, or you can have low volume with a high concentration. And it's also really important to remember that most sperm samples have hundreds of thousands of sperm, some have millions. We typically, a typical cycle, we might get 10 to 20 mature eggs. So we're only using 10 to 20 of that sperm. So our eggs are more likely to be our limiting factor than our sperm. And then down at the bottom, you can see that the components we're looking at is the overall volume. And then, like I mentioned before, the concentration, what's actually inside that volume of sperm. And then which of these sperm are actually swimming and swimming productively. And then the morphology aspect is, what do those sperm look like? And you can see on the right side of the pictures that there's many different abnormalities that we see in sperm. And when we're doing ICSI, so when we're injecting one sperm into each egg, every embryologist is searching through the dish to make sure we're finding the best possible sperm. You can also do conventional insemination, which is when we just take a group of eggs in a drop and we just add sperm to that drop and let them fertilize themselves. In that case, we're not able to pick which sperm fertilizes which egg, but some patients prefer that method since it kind of resembles a more natural aspect of fertilization. Next slide. So day 0 retrieval day, like I mentioned before, is also our day when we're inseminating our eggs. Most of our cases are ICSI cases. So we're taking one sperm and we're injecting it into one egg. To do this, we do need to determine maturity. So if you have 10 eggs retrieved, it doesn't necessarily mean that all 10 of those are going to be mature and able to be fertilized. And you can see the top picture kind of shows you on the left-hand side a holding pipette we use to stabilize the egg. And all of this is done under a 200x magnification microscope. And then the right side is the injection pipette, which carries the sperm. And then down at the bottom, you can see that video replaying of that. It's a little bubble that you see in the needle, and that's what the sperm is. So our job is to penetrate the egg and then drop that sperm off right in the middle. And then we let the egg sit overnight and hopefully fertilize. Next slide.
Okay, so after my retrieval, I was waking up from anesthesia and I found out that I got 6 eggs retrieved. And then the next day I got a call saying that all 6 were fertilized, which is a huge deal. I remember, laying in bed in recovery mode, taking that call and just being so grateful that all of them fertilized. And then, after that, it's kind of you get updates from your doctor on where they are in their development cycle of days. So I found out that 4 developed into blastocyst, which all 4 we biopsied and did genetic testing. And then those 2 long weeks of waiting. And we have now 2 genetically normal embryos waiting for us. So we're very excited. We feel very blessed. We know a lot of people that have my same situation of low AMH, and they don't get as many eggs like myself. A lot of people who freeze their eggs, they're fortunate enough to freeze like 10, 12, sometimes 20. And so my mind automatically thought, okay, I'll get maybe 10. So I was happy with 6. However, I did think like I had 15 follicles. How come I didn't get 10 eggs? But through the process, you just have to be so grateful for what you end up getting, because you put your body through a lot with those medications, and you just have to be grateful for what your body produced.
Did you have moments where you felt like, you're not getting this perfect outcome that you wanted and this is never going to happen? Like, your moments where you're just like, the world is against me. I'm not going to get anything. Uh,
Um, I did have doubt on the mostly the after the fertilization, I got nervous. But when we found out there was only 2 out of the 4 embryos were genetically normal, I kind of was like, okay, well, that's 50%. That's pretty good.
yeah.
Like knowing that I'm not going to have a lot to begin with, like I'm
Yeah.
just really happy with our outcome.
Yeah. And that's when you mentioned this before, you have your age on your side. So
Yeah.
an older patient who has 6 retrieved and 6 fertilized, there's a large possibility that there will be nothing that develops to that threshold of being able to biopsy. And then dealing with that disappointment, the disappointment is not just emotional, it can also be financial. And
Mhm.
it's, when I talk to a lot of my friends that are going through IVF, I say, IVF is in a stage where you'll get there. The road just might be rocky. And I think that's a really important thing. You might have to do 3 retrievals instead of 1 retrieval to get the outcome that you desire. And there's going to be a lot of bumps and um, things that don't go the way that you anticipate or you would like. For 99% of our patients, we'll get you there. It just might be a little bit longer road than one would hope.
Yeah. Yeah, I definitely, anytime I thought that I was having those negative thoughts, I reminded myself like this is a day by day basis. I need to just focus on today.
Yeah. I think we get that question too. A patient will call on day 3 and they're like, well, how many do you think will make it? And again, it's a guessing game. There's no secret code we use to say, oh, this embryo is 100% going to be able to be biopsied. that's the thing about science and this developing embryo is it can turn right or it can make a left-hand turn and stop dividing at any time. We do have general percentages. We typically expect about 70 to 80% of our eggs to fertilize, and we expect about 50% of those to make it to the blastocyst stage. But again, some patients will have less than that and some will have more than that. So we can provide ballparks, which I think sometimes can be even more frustrating for patients because then they just go and they Google and they convince themselves that they'll be in the percentage with nothing biopsied. And so it's hard to not know. And then it's hard to be on the other side, not to be able to give the patients a black and white answer. So yeah, next slide. So on day one, we check for fertilization. And now the embryologists now refer to them as zygotes because they're fertilized, they're starting to develop. They're not embryos yet, but since they have a sperm inside of them, they're also not eggs. And you'll see the picture on the right is showing you a normally fertilized zygote. And it has 2 pronuclei within that egg. And then you'll see some tiny little nucleoli within that. An egg can also have 4 of these PNs. It can have 1, it can have 0, and those are just different versions of abnormal fertilization. Labs, so we're lucky that we have the embryoscope because it allows us to look backwards and see, what's happening in development, and these PNs will also fade at a certain time point. So it's possible, and this is not good or bad, this is just variation, that your egg can fertilize and those pronuclei can show up and then they can disappear and fade by 5 a.m. So our embryoscope allows us to move backwards and to check to see did these exist and they faded, or did they never exist? So the other side of that is a benchtop incubator, and the only thing we know about these embryos is when we remove them from the incubator and we look at them under the microscope. So we just have one time point that we're using. So we could miss the pronuclei, or they could have never been there. We're not sure which is the option. So many labs, if it's a 0 PN, if there's no PNs present, we will also keep those because, like I said, they could have disappeared. Or if it's a 1 PN, because one of the pronuclei could have disappeared and we wouldn't know it. But when you see 3 or 4, you know that that's abnormal fertilization and your chromosomes are not the proper number, so those will be discarded. Next slide. Okay, so then this talks more about after your day 1. So from your day 2 onward to day 7, what is your embryo doing? And again, this is a video from our embryoscope incubator, which takes pictures consistently, which creates these videos where you can see development occur. And so the first, from day 1 on to about day 3.5, you can see that your embryo is increasing in cell number. The cells themselves are getting smaller, but they're increasing in number. And then around day 4, we have what we call a morula, when all of those cells compact, and then it forms a blastocyst. And our blastocysts have 2 cell types. You have your inner cell mass, which creates the fetus, and you have your trophectoderm cells, which support the fetus and create the placenta. So in the video now, you see a morula forming. Now you have a blastocyst, and that ball up top, the tight ball, is your ICM. And then all of those moon-ish scalloping cells is your trophectoderm. And at the blastocyst stage, there's about 200 cells. Your day 6 or day 7s can have even more cells, 300, 400 cells. And when we're doing the PGT testing, we're removing 6 to 8 of those cells. So it's a very low number compared to the total number of cells that the blastocyst has. So again, here you're about a day 4 embryo coming up now. Now you're about day 5, and now you have a perfect expanded blastocyst. Okay, so embryo grading is another question we get a lot by patients. And the first thing I like to tell patients is the most important part of your embryo is, did it reach the blastocyst stage? And then if you did genetic testing, what was the results of that testing? The difference of a 4BB and a 4CC has a very insignificant difference in its ability to implant and create a baby. So I try to remind patients not to get too caught up on what your grades are, but what were they frozen on? What day were they frozen on? Day 5 or day 6 or day 7? And what was the genetic status of that? And then Brittany can give you some details on her embryos.
Yeah, so the photo at the bottom right are my 6 embryos. And I'm fortunate enough to have Robyn and talk with her along with my process. So I know I'm very fortunate than like the average patient. But honestly, it helps with all this information in providing this webinar to everyone and showing you what I got to see. So the very top row, embryos 1, 2, 3, and 4, we're looking pretty normal, developing normal. And then I saw the yellow box, and that's when I remember asking you, like, what does yellow mean?
Yeah, so yellow means that there's just an abnormal division, something like I mentioned before, your embryo is increasing in cell number. Sometimes it increases incorrectly, or the cells can fuse back together. And that development, our research suggests that that can decrease the embryo's ability to implant. So we mark those embryos, and when we're putting all of your embryos together and choosing the best one, that one automatically gets pushed down towards the bottom and would not be your first embryo that we would choose for transfer if it
Yeah.
got frozen. I think in your case, it didn't meet the developmental threshold to even be biopsied, right?
Yeah. Yeah, both 5 and 6. So the bottom two did not make it to,
Yep.
I believe, day 4 even.
Yep.
So those we will not be using. But the top 4 were good, and those were biopsied and sent off for genetic testing.
And your embryos number 1 and 2, you can tell the size is a little bit smaller than your 3 and 4. And so when we're grading the embryos, we give it a number, and the number reflects the developmental stage. So your embryos number 1 and 2 would have gotten a lower number, like a 2 or a 3, and embryos number 3 and 4 would have gotten a grade of a 4. And then we also assign letter grades, which reflects the quality of your ICM and your trophectoderm. So in your case, embryos number 1 and 2 weren't bad embryos. They were just developing a little bit slower. So that's why they were left in culture overnight. We didn't biopsy them on day 5, but your embryos number 3 and 4 had expanded. They had a great amount of cells, and they were ready. Part of this is being ready to be biopsied, right? We don't want to biopsy or freeze something that still needs some more time to develop. And that's why your embryos number 1 and 2, we left in culture and then ended up biopsying them on day 6. Next.
Great.
Okay, so our PGT topic. Most of our patients opt to perform PGT. It obviously provides more information about the health status of that embryo. It's a screening process. So if you're not doing PGT and you have 4 embryos frozen on day 5, we have less information that tells us which one is the best one to transfer. So when you do PGT, it helps us screen out the chromosomally abnormal ones so we can transfer the best one. And then hopefully you have to go through less transfers. Some patients also opt in for the testing for family balancing. If they have 2 boys and they're looking for a girl, the genetic testing will provide that information as well. And then there's many different types of testing. Most patients do PGT-A, which just looks at our chromosome numbers of the embryo itself. You can also do PGT-M, which gets into more specific inherited diseases such as cystic fibrosis. And then below are Brittany's results.
Yes. Yeah. So, when we were developing this presentation, I didn't even see these. I knew I got a call from my doctor saying that, two of my embryos came back genetically normal. But I had positive and negative feelings about that because I was like, oh man, it would have been nice for all four to be normal. And then when I have like a lot of more options. And so after looking at this, you kind of explained like what everything means. And, I'm looking at it now and knowing the details of the genetic testing. I feel so much better with, understanding more of the details behind what happened with the other ones that aren't genetically normal. And also, I have a son already. I would love to have a daughter. And so that was like our main concern going into IVF was, oh my gosh, what if we end up with all boys and we don't get that girl? Um, so seeing that, out of the four, two were female, two are male, and we ended up getting one of each that are genetically normal. I feel very blessed in that. And then if you could just explain like the positive portion, because I remember
Yeah,
like,
so
looking at it and I was like, oh, those are the two good ones. And you were like, no, that's
so it depends on what company is used. This format will vary, but in this case here, positive. So for embryo number one in that first line, it says positive, and it says minus 13 and plus 16. So what that means is it is the embryo tested positive for an incorrect number of cells or chromosomes. So it's missing. So we also have two copies of every chromosome in these embryos. So you should have two copies of chromosome 1, 2 of 2, 2 of 3. In this case, embryo number 1 was missing a copy of 13 and had an extra copy of 16. So it was monosomy for chromosome 13 and trisomy for chromosome 16. And one of the most famous trisomies is trisomy 21. So we know that that is compatible with life, but sometimes it has the potential to decrease the quality of life. But all chromosomes have the ability to be missing a copy or have extra copies, and they all have their own set of implications. Embryo number 2 says positive as well, and it has an extra copy of chromosome 3 and is missing a copy of 16. So again, it's missing a copy of 16 could mean that the baby would have severe heart problems. And I don't know exactly what, I would have to look up what 16 means. But like I mentioned before, they all have their own implications, but suggest that the health of the embryo is decreased. So then your embryo number 3 and 4, those are negative for any abnormalities in the proper number of chromosomes. And those would be the ones that we would look at first to choose for transfer.
yeah, and we discussed like I wanted to know from like your perspective when we were going through this is what would be a hindrance on not transferring those that aren't chromosomally normal? And something that you said to me that really stuck out, and I was like, okay, that kind of changed my thought process was, do you think mentally and emotionally you can handle a failed transfer? And I said, there's no way. Like this process has been so emotional, like even presenting now, like as we're talking about my results, like I do feel the emotional side of the process and just reliving everything. So yeah, I that really helped me decide that there's no way I'm gonna transfer those because I just can't handle any more heartbreak.
Yeah, and I mean, you know this as well, that even the healthy embryos don't have 100% chance of creating a baby, and they still have a potential, although smaller, less significant potential of not creating a baby. And that's why I think, we tend to lean on more PGT cases because it's screening out those embryos that have less potential right away in hopes that we can get you pregnant and get a baby, a healthy baby, faster. Um, and then the video on the right is just keeps replaying the process of the embryo biopsy, and you can see those 6 to 8 cells being removed from the embryo. And that embryo, if you look at it 5 minutes later after this process, you can't even tell anything. It looks the exact same. So they're pretty strong already on day 5, 6, and 7. And then those cells that you see in the tube are the cells that we send off to the genetic testing company. Next slide. Okay, so cryopreservation, our freezing procedure, we get a lot of questions on, and this video on the right is showing you a cryo tank. So this is where we keep all of our embryos, sperm, and eggs. And you can see the cord that you see connecting is our alarm system that notifies us 24/7 of any issues. The patient's name is labeled on the top of the cane, on the side of the cane, and then on the devices themselves. So this yellow straw is where eggs and embryos are frozen. And then you can see, this is just a Jane Doe example, but it would say your name, the date frozen. If it's an embryo, it will say which embryo is frozen. And it comes with a specific identifier. So we use accession numbers that are unique, which will also be on that device. So our tanks are monitored 24/7. We get up at 3 o'clock in the morning if anything goes off. And it's a multi-layered step process of witnessing and making sure that we are collecting and using and thawing the correct specimen. We also use a second witness. So this process of, if this was a real patient, there would be a second embryologist standing next to this one and would also be witnessing that this is the correct patient that we need to thaw today. Okay, next slide. And then transfer day. This video on the right is kind of the lab's perspective of what goes on. You can see a second embryologist is identifying the paperwork, the patient label, and the dish to make sure everything adds up. That video on the screen also shows in the transfer room, so the patient is able to also make sure that the correct dish is being used. And then this is the catheter that we use. You can see the very tip of it is bendy and soft, so hopefully it's a more comfortable process. And then the embryologist is loading up that embryo, and that's exactly what she hands off to the physician, and the physician will find the correct placement. Again, it's a multi-step identifying and witnessing process here. We have so many protocols in place to make sure that the correct embryo or anything is being used for the correct patient. Right? And then this is what one of our rooms looks like from the other side. And you can see in the very top corner, the reflection in the mirror is of that screen and of that dish that the patient is able to ID themselves. And then Brittany, you want to go through the monitoring?
Yeah, so you'll kind of go through a similar process that you went through, not exactly the same medication, but you'll still do lab work and ultrasounds before your retrieval to kind of make sure your body is preparing. The focus is mainly on uterine lining versus your follicle count. And then the frozen embryos are thawed, day of transfer. You can come in the day of transfer, and if you're nervous, you let the staff know. They can give you, I believe it's Valium to kind of relax your nerves. And what's really great about the transfer day experience is that you're laying there, you're there with a nurse and your doctor, and the in the previous video that you saw in the lab, that door is right next to the transfer room. So there's not a long walk from where your embryo goes from the lab to you. It's literally just one doorway. It's very, very close. And then after 10 to 14 days, depending on your doctor and what they recommend, you can take a pregnancy test blood test is best because then they can kind of capture early signs of pregnancy. Or you can wait the 14 days and take a urine pregnancy test. Very fast, quick uh, experience with the frozen embryo transfer versus the retrieval process.
Yeah. And we don't recommend making any changes to what you want to thaw the day of. So the lab will thaw earlier in the morning of the embryo that's been chosen by you and your physician. We do have a few patients a year where they get into the transfer room and they change their mind. It's all possible, but we have to refreeze that embryo, which could possibly lower its potential in the future. So we like all of our patients to be making 100% the decision with their physician well in advance of the transfer. Next slide.
So we're running some promotions right now. The first one is with Dr. Diana Chavkin. She is a new physician with us. She joined us in May, and she wanted to offer all new patients of hers a 25% off your first retrieval cycle, whether you're freezing eggs or you're going the IVF route. She wanted to expand that offer to anyone, and then you would also get 50% off your initial consultation. That promo, it ends on August 15th. So call us and book an appointment. Next. And then we also have an in-person event coming up in September on the 26th. It's a Friday at our Beverly Hills office from 4 to 6 p.m. It is free AMH testing plus a free virtual consult. And we hope you guys join us. The space is limited, so please go to our website and fill out the form to reserve your spot, or you can call us and get on our schedule. All right, like I mentioned before, we have 5 amazing physicians. We have Dr. Suri, Dr. Danzer, Dr. Alexander, Dr. Maxwell, and Dr. Chapkin across all 4 of our locations. Next. Okay, if you guys have any questions for us, you can submit them in the Q&A box or in the chat. We'll be looking at both. Any questions that you have at all about the lab, the patient's perspective?
I have a question for you.
Yeah.
Okay, so if you have 2 day 5 embryos, one's a boy, one's a girl, they're equal quality. So they have the exact same potential for implantation. If your girl embryo was frozen on day 6, so it has less potential than your boy embryo, let's say 15% chance less of implanting, which embryo would you choose?
Well, I would pick the girl just because I have a son already. But if I didn't have any children yet, I probably would go with the most healthy because my journey has been so long already. I don't want to wait, or I don't want to say waste time, but I want to make sure that the outcome is positive as soon as possible, which is most patients.
Would you think about doing another retrieval?
Um, I think if like my real decision, for me and my family, we would definitely transfer the girl first.
Mm.
And if that didn't work out, which I'm gonna manifest it, it's going to happen. Um, but if it doesn't, I probably would go another round of IVF, just so I have a future daughter, you know.
Yeah, yeah. Before you use your second embryo, you do another
Yeah, and my egg quality is really good at my age now, versus
one.
like in a year. So I don't want to lose that time and opportunity.
Yeah.
Yeah.
There is a theory that if you do one retrieval and then you do a second retrieval the next month later, you might have more eggs or a better outcome. And physicians will know more about this than me, but there's something about like stimulating the follicles and then doing it again, that sometimes if you do that two in a row, which sounds like an
Sounds
extra
so
month.
crazy. Like,
Yeah. But maybe worth it. I don't know. So yeah.
I definitely remember thinking, I cannot believe people do back to back. Like when you go through it in your body and you're like, There's no way I could do this again."
Mm-hmm.
But I think if you give yourself like a month off or 2 months off, you could probably do it.
Yeah.
But yeah, I was told that even just after the retrieval, that it like stimulates your follicles for the next cycle, and you could possibly get pregnant naturally, which we tried to do. It didn't work out. But it did stimulate a lot of eggs when we decided to do a second IUI. And so I remember my doctor saying, "You're gonna need to go home and have a serious conversation with your husband that you're most likely gonna conceive twins this cycle. So you either need to decide if you want to, like stop the cycle and the medication and wait, or be okay with twins." And so I went home, I told him, and he's like, "Okay." And I was like, "Well, of course it's okay for you. You're not carrying two babies."
Yeah. Yeah.
But yeah, that, it's very unfortunate with, my age, and transferring an embryo is a little scary
Mm,
personally, just because I've only known negative pregnancy tests in
mhm.
the last year and few months now. So I'm kind of procrastinating to transfer.
Well, I mean, you and I have mentioned this to each other before. A big part of IVF and your success is stress. And I don't know if it'll ever feel right, but you have to listen to your body a lot. And it is a good test of, listening to your body and knowing your limits. And can I handle a negative pregnancy test this month? Or do I just need to take a break? And not that it'll ever be perfect timing or ever easy to hear. Um, but I think knowing your limits and what you can and can't handle will reduce your stress and increase your chances.
Yeah. I know a lot of people ask the question, what's the difference between PGTA and PGTM, and why wouldn't you go both routes? How would you answer that question?
PGTM is really only used if you or your partner have a known disease like cystic fibrosis. So so we have our two pairs, our pairs of each chromosome, right? On those chromosomes, there are hundreds of millions of billions of genes. And PGTM is looking at one specific gene. So you're only doing PGTM if you know, so that's a big part of before you undergo IVF, you do your carrier screening, right? And then your carrier screening brings back 400 results for different diseases. And and also different diseases, if both of you test positive, you'll have a big chance of your offspring carrying that. So in that case, you would want to do PGTM, test that one gene, and make sure those embryos don't have that carrier. You wouldn't do PGTM for cystic fibrosis if neither one of you are carriers. So that's the big thing with cystic fibrosis is you can be a carrier but not be affected. But if your husband is also a carrier, then you'll have a dominant disease and your offspring will have a higher chance of being affected by cystic fibrosis. So you really only do PGTM when you or your partner are carriers or have known diseases.
Okay. Let's see if we have any questions. Feel like we might have answered everyone's question during the. I think maybe a question that people might not think about is if you were on the patient side, what are some questions that you would want answered if you were going to other clinics? Like, as far as like lab goes, like what are the top questions to know about fertility clinics and their labs?
So in IVF and especially in an embryology lab, there's not one way to do something, right? And I kind of touched on it when I said some here at our lab, we don't do day 3 checks on embryos, but some labs will. And there's not really a right or wrong answer. It's just how each lab is set up. So same with grading embryos. There's different methods to grading embryos. Um, there's different ways to do a lot of things. I think the more important questions, it's not, is one lab doing it right? Is one lab doing it wrong? It's even hard to look at results. So and one lab might have 70% fertilization, another lab might have 80%. But what they don't tell you is that lab with 80% only takes patients between the ages of 30 and 35, while the lab with lower fertilization will take any patient that needs help. So I think that the most important part of IVF, again, is decreasing your stress. And one of the best ways to do that is to be on the same page with your physician. So different physicians also have different personalities. Some will hold your hand through the process. They'll explain every aspect of IVF to you. Other physicians will spend less time talking to you, but it doesn't mean they're not paying attention to your cycle. They're just reading your chart, making decisions, and doing what they think is best, but they might not walk you through that. And for some patients, being walked through everything creates more stress. For other patients, it relieves their stress. So the most important part is be on the same page with your physician. Be in line with how they run an IVF cycle and what is going to help you decrease your stress. If you want your physician to pick up the phone every time and speak with you, that's a good question to ask during your initial consult. Some physicians will have their nurses do it. Some labs won't give you that update until day 5 because they don't want to give you any false hope. So ask the questions, know what to expect, and then, say, talk with your partner or make your own decision. I didn't really feel like this physician understood me or understood what my needs were going to be. And I think everything stems from that.
I like that. Yeah. I definitely was the patient that wanted to know everything. And now I'm like, oh, I kind of wish I didn't.
I,
Because it's like in the back of my mind, like, okay, but if we do this, then I know it's this, this, and this. And ooh, I wish I didn't know. I wish
yeah,
I just took it day by day, step by step, and
yeah,
kind of followed a little bit blindly. Yeah. But I did ask ChatGPT. I was like, what are some good questions? Like I told ChatGPT, like, this is my results, this is everything that I know.
yeah,
And I was like, come up with some questions to ask my doctor. So
I like that.
technology always helps in some way.
Yeah, I think in your initial consultation is the best time to answer questions. I think that's when your physician has time set aside. I know some of our physicians will have like a PowerPoint slide, so they try and educate you and give you the overall process, and it can be a little overwhelming. So do your little research beforehand, and like you ask ChatGPT or talk to your other friends who have gone through IVF and find out what your questions are and just come prepared to that initial consultation. And I think that'll get you really far, and I think that helps with the overall process and managing expectations as well.
All right. Well, there's no more questions. So we're going to conclude this webinar. Don't forget you get 50% off your initial consult for joining us today. And then also take advantage of our in-person AMH event in September. Go to our website. It's also on our social media. We have a lot of educational content on Instagram for you guys to absorb and digest and understand a little bit more on your next steps. And we would love to see you in person. So make sure you reach out to us and schedule your consultation. All right, bye.